wonderful morning of speakers we've had just now, and our last two speakers in particular have really set the context for this discussion which we're about to have. If I can invite the members of the panel up to this table just now. You've been introduced to all of them before. Victor is going to be joined by Chuan, by Andrew and by Caroline as we begin to explore some of the issues around about recovery, reform and sustainability in this question session. I think if I can just say a few comments just to introduce this. We are at a pivotal moment, aren't we, for healthcare? Not just in this country, but I think globally. And the presentations that we've heard so far today and for the rest of today actually reflect some of the work which is going on across Scotland to try to meet those challenges that we currently face. First thing I wanted to do was actually just to thank each of you from the RDI community for all the work that you continually do to make progress with some of these challenges. And whilst I've got this opportunity, because I don't often get the opportunity to see the three of them in the room at the same time, is to thank three wonderful colleagues, chief scientists that I've worked with presently and in the past, Anna, David and Andrew, for the support that you've given to me over the years that I've worked with you as well. You have been incredible colleagues to work with as well. In my annual report this year, I outlined 4 major challenges that we currently face in relation to population health in Scotland. First of those is about communicable disease and how we continue to meet the threat that exists in relation to infectious disease, antimicrobial resistance and vaccination. Second is, well, has already been mentioned, declining life expectancy. We've seen that in Scotland. We've seen stalling life expectancy that stretches back 10 years now to 2012. We have the challenge of sustainability in healthcare, particularly in the face of some of the projections for the burden of disease that we're likely to see over the next 20 years. And one that I haven't heard mention of terribly often yet this morning, but which I think is one of the biggest challenges that we face is is in relation to the health impacts of the climate emergency, both health's contribution to that climate emergency, but also the changing nature of health and disease as a consequence of that today. I've jotted down some words that I heard over those last two presentations that I didn't expect to hear today. And I'm really grateful that you've brought them into the presentations, because I didn't expect to hear so much mention of equity, of population health, of value, and of trust and relationships. These are aspects that I think are absolutely critical in this next period. So I'm delighted to be joined by this panel today as we begin to explore this. I'm going to start with some questions of my own before I pass it to you in the audience so that we can begin to receive some of your questions. I want to start, Caroline, first of all. In a health system such as we have, which is under pressure, how do we make sure that we prioritise RD&I as an activity which is both important but critical in showing us the path through some of those challenges?
Thanks very much for that, Gregor, and it's a really good question, particularly as we're going into the whole process of setting the budget for 24-25 in an incredibly challenging context. So, we know that health services are under unprecedented pressure, and we've had a lot of discussions already today about that increasing burden of disease, which really has the potential to overwhelm systems. So I think really, part of your answer to the question, Gregor, is that we can't afford not to invest in research, development and innovation. And we need to think about research, development and innovation in terms of how it can help us at both ends of that spectrum. So how it can help us in terms of that prevention and early intervention. And I was, like you, Gregor, I was delighted to hear so much emphasis on the word equity, because actually using how we can use research, development and innovation to address some of our really acute health inequalities challenge, I think is going to be fundamental towards that whole area of prevention and early intervention. But at the same time, I think we have to recognise that we've got a lot of what I call baked in ill health in our system, and therefore we absolutely need to look, and again, been making notes to myself of the things that I want to ask questions about later in terms of, some of those innovations that can absolutely help us to improve access to people, bring services closer to people's homes, but also improve the efficiency, productivity, and eventually the health outcomes of people in Scotland. So really important.
Thanks, Caroline. Chuan, if I can turn to you. First of all, thank you for your presentation. I've really enjoyed it. And I want to touch on one of the parts. I think one of the features that I noticed of the pandemic response was the can-do attitude that people adopted to get things done quickly, a very collaborative style. And you mentioned this concept of creating value. Now, what I saw from your presentation was actually perhaps a requirement for us as clinicians to be boundary spanners, to look beyond our normal sphere of influence and begin to work with other parts of the system, if I can call it in those loose terms. What's your perspective and your view of how clinicians and health scientists should be working in the future?
Yeah, thanks. I was Chief Health Scientist for about 5 years, and I saw it very much the role of Chief Health Scientist to bridge between the world of research and academia and policy makers. And what we have tried to work on was kind of a dual-track system. The first part of it is for policymakers to be clearer about articulating what their priority needs are and to translate them into research questions and challenges. Otherwise, it's very vague. And so we have tried to set up a system whereby the people who are implementing real change on the ground are also involved with helping us develop innovation challenges. And the example I would just share is in the area of aging. We have an aging program office, and two of the priority areas are frailty as well as caregiver ecosystem. And as they are thinking about how they want to change the way in which these things are delivered, we have asked them to formulate challenge questions, which we then put through an innovation challenge with a $10 million research grant. And the way the research grant works is different applications can come up, and we shape those applications so that we bring the best people and best ideas together in a coherent manner that would produce results that are likely to help inform policy. So that would be, in a way, a more thematically defined, somewhat more top-down policy leader-led type of a discussion. But at the same time, we also want to encourage ground-up innovation. And the approach that we are trying out in Singapore is, as we see interesting things coming up, we ask ourselves, how do we enable these ideas to be more quickly tested, brought to the attention of policymakers, and hopefully adopted? And this means, therefore, we have to think in terms of the major bottlenecks. Why is it so hard for innovation to be validated and scaled in the health system? It's because most researchers and institutions cannot simultaneously overcome the barriers of change management, integrating with the IT system, getting hold of the data, and getting someone to fund it. And if you do one or either of these, that's good, but it's not enough. And so we are trying to set up systems in Singapore where we provide clearer pathways by which the funnel of ideas that become more and more appropriate or relevant for health priorities could be accelerated through this process. I would say it's not done yet. I mean, this is still very much work in progress. It's very difficult. But what I'm describing is how we are thinking about it and what we are actively trying to shape. So I think those two approaches, we hope, will then help researchers to better understand and to make an impact in areas of health priority, which actually, when you ask the research community, many of them want to do that. They want to have impact. The problem is it's very hard to do so because the pathways by which you can create impact are very unclear and difficult. Thank you.
Thanks, Joshua. Victor, I'm going to turn to you now. And again, thank you so much for your presentation. And hearing equity features so much in it, it's something that's very important to us in Scotland just now, particularly important to me. I want to turn to one of the things that we speak about. We speak about a just and a fair transition. as Scotland tries to meet some of its ambitions in relation to net zero. And within healthcare, we've set ourselves fairly ambitious targets to become a net zero healthcare provider by 2040. I'd love to hear your views on what role RDI has to play in terms of that transition in a just, fair and equitable way towards a net zero healthcare provider in these incredibly challenging timescales.
It's an absolutely important issue in terms of climate and environmental justice. Certainly at the Academy, we spend a lot of time working on this, and we are in some way the convener across the U.S. of some leadership, including the government, to look at this issue. You know, you come way ahead of the United States. I think your net zero is 2045.
2040.
2040, wow. Good luck. We're talking about 2050, and maybe we can get there. And of course, I do know that you are already in many ways ahead of so many others, because 95% of your gross electricity consumption is from renewable sources already. You have one of the first floating wind farm and tidal turbine. It's very impressive. So I think when you think about climate and health, I think about the following way. One is climate change lead to health is a public health crisis because of what it does to health. And secondly, of course, our role in terms of care, also in terms of reduction of carbon emission. Let me talk about each one of them. I mean, we do know that air pollution kills about 9 million people globally a year. If you look at the total data of climate-related deaths, about 20 million a year. It's actually phenomenal. And of course, you know, the range is extreme weather. I think you guys just said your big storm, right? Barbet, I think, right? And extreme weather, heat, famine, drought, air pollution, vector-borne disease, you name it. So this is a very, very important issue. And of course, as health sector, our job is to be able to provide the health emergencies during these extreme weather events, but also being resilient enough to be able to work with these extreme event issues, and of course also care for the chronic diseases as part of climate, such as air pollution, you name it. So we have a lot of work that we need to do there. But I think all of you know that we also actually a major emitter of greenhouse gas. In the United States, we respond for 8.5% of total carbon emission of our country. And I think yours about 4 or 5%. Yeah. That's huge if you think about this. And so we do have this responsibility to do no harm, but also, as you said, can we leverage a way by which we can reduce carbon emission, but also at the same time improve outcomes? I think that's where it is. And I think research and innovation really takes a big role. For example, you take a step back and ask, what are the main reasons for emission? You all know about scope 1, 2, and 3, right? So going in scope 1 is directly that we actually emit as a cost of healthcare. Scope 2 is, in fact, what we do indirectly through purchasing, et cetera. And scope 3 is all the related industry, supply chain, biopharmaceutical, manufacturing, device, you name it. And the majority of emission actually comes from scope 3. So to do this, you need to get all the parts of the health sector work together, and not just healthcare, but also pharma, industry, supply chain, you name it. That, in fact, is how you can get there. But in terms of what we can do, I think very much along the lines of when we're looking at healthcare and what we do innovation in terms of quality and safety, is mobilizing ways in which we provide care which is better for the patient, in this case, lower for admission. That's called care redesign. Think about during COVID, right? I mean, the fact that your patients have to come to your clinic, driving through Glasgow, and emitting all those carbon from transportation, I think virtual care is really taking a lot of that, a lot of this. But importantly, I think when you can deliver care at home, right, actually it's better for the patient, and it's probably more for prevention. So all told, I think a redesign of the way we do healthcare is one of the innovations we can do. So I know that NHS spent a lot of time talking about care pathways, but now it's time to think about, well, is our care pathways for diabetes or for this the right one? Do we need to bring into consideration the issue of sustainability and change the healthcare and measure the outcome? Second, of course, is to look at data. I think we talk a lot about climate and data and health, but truthfully, I bet you don't have very good data in Scotland, right? Now, who are the vulnerable population? And what are the interventions, and would mitigation make a difference that can help policymakers? So implementation science, really, really important area. And then, of course, if you look at how much waste that we generate in our healthcare, and I do think you have a program about reducing PPEs, right? I mean, it's quite amazing. Go to the operating room one day and you can look at how much disposable there is. It's become a huge industry. Now, we know we got into that with the idea that you want to reduce infection, but I don't think any recent data have looked at what the right level is. And waste reduction, circular economy, another area which I think there's a lot of innovation needed. And of course, incentivize innovation of every one of your frontline workers, as we did in patient safety and others. And then finally, the private sector. I do think there's a tremendous opportunity for private sector, entrepreneurism, packaging, transportation. As you know, I think you guys are already planning to electrify all your vehicles, right? Mm-hmm. I mean, that's what you need to do. So there's a tremendous amount of research innovation, I think, possibility in addressing this issue.
Thanks, Victor. There's so much in there in what you've said, and the thing that I'm struck with by, wouldn't it be wonderful if in the future we had the data that allowed us to actually assess the carbon footprint of each pathway or treatment that we initiated, so that we could begin carbon accounting for the way that we actually deliver care as well. To that, we need good data.
So if I may, I think in our collaborative, we have the head of Medicare, Medicaid Innovation. We have insurance company, Andrew Whitty co-chairs this with me, and we have the assistant secretary. And what we're talking about exactly this: do we actually change reimbursement, value-based payment that includes carbon accounting, that includes other issues as well? And I think insurance company can do a big role in this case. If you look at what they're now doing in terms of paying for social care, I think you can look at what you can do to incentivize sustainability.
We clearly need to have more conversations. Anna, thank you. Andrew, I'm going to turn to you just now. And I guess the point I was going to make was about data. And we need consistency in the use of the data and adoption of ways of collecting data and implementation of digital infrastructure. From your experience working with HDR UK, I mean, what are your observations about the approaches that we've taken, and what do we need to do to get better at that?
Okay, so a few thoughts. And I would encourage us all, despite the headwinds we've heard about, Scotland should be ambitious. It should be bold, enterprising, and ambitious looking forward. So a couple of thoughts on the data piece. Firstly, I've got some mic. Firstly, we should not underestimate the inflection point of the so-called fourth industrial revolution that Victor talked about. We're seeing a fusion of biology with computational sciences, physical sciences, and social sciences. And this is here to stay. So as you know, our esteemed Prime Minister, Rishi Sunak, is meeting Elon Musk tomorrow at Bletchley to talk about the ethics of AI. This is a far more exclusive conference, Anna, I should say. So this is coming. It's disrupted every other industry vertical in every country. Health is a relatively latent adopter, but it's coming. And our opportunity is embrace this revolution in a trustworthy and equitable way. And I think Scotland could be at the forefront of that, to be honest. Key is this convergence of disciplines. So let's do, I'll have to do a quiz, Gregor. So my definition of data science, which you heard from Chorh, Chuan and Victor, is the interface of maths, statistics, computational science, and domain, and we're healthcare. So how many mathematicians in the audience? One.
No.
Welcome.
No. We've got a couple of declarations up here.
Are you at the right meeting? Any
You're very welcome.
any statisticians? An outlier. any computational scientists? And the rest of us, domain, healthcare deliverers, clinicians, etc. So when we come back in 2073, Anna, I want to see an equal distribution, because our colleagues in these other disciplines have so much to offer us. So let's converge. So that would be my first comment. The second comment is, if you look at the best performing health systems internationally, which deliver equitable, high quality care at reduced cost, they have certain characteristics. And I would argue Scotland has many of these characteristics. Firstly, a focus on quality and the 6 dimensions of quality. Secondly, strong leadership, which is managerial and clinical leadership aimed at the same vision. Thirdly, a strong primary care. Fourthly, and I'll whisper this one, financial stability. But they have 2 other facets. Firstly, they have whole system intelligence in real time, which allows you to track journeys of care of patients across primary, secondary, tertiary, and increasingly social care. And you heard the power of that from Aziz today. And lastly, they have baked research and development into the health system at scale. So if you go to the Mayo Clinic, the Centre for Innovation is next to the canteen, and it's part. So you have the Kens of Rochester actually in the Mayo Clinic, co-creating and innovating. And I would argue that Scotland's got many of those facets. But to do that, and this is my final point, we need to consider data as infrastructure. We often see it as a sort of peripheral activity. We need to see data as core infrastructure for the design and delivery of health systems, to deliver this whole system intelligence. And if you do that, you deliver 5 things. Optimization of care, which is why we're here. Secondly, population health management stratification. Now, in diabetes in Scotland, 20 years ago, we reduced amputations by 40% in 4 years because we tracked journeys of care of patients. Why are we not doing that for cancer, cardiovascular disease, mental health? So population stratification. Thirdly, management of the health system, focused on productivity, which is a big issue. Fourthly, augmentation of clinical trials. And lastly, the research and development, automation of AI. So I think what we've heard today from Chorh Chuan gives us a great framework to actually think, how can Scotland, we've got all the ingredients, it's about weaving them together into a coherent delivery program.
Fantastic. Well, listen, let's open this up to you now.
Again, may I respond to Andrew? I think what you said is perfect. In our country, the other 2 issues are public health and community care and social care. So beyond the healthcare paradigm of general practice, primary care, specialty care, integrated system, is the need to integrate with public health. We saw this in our country during COVID when we have CDC, the federal, we have state and local public health, we have hospitals, and the data, as you said, are not shared and they're not integrated. But if you look at the overarching direction of health, I think the public health and social and community health is a central part of this.
The health system of the future has to be built around a strong community health care programme. That's for certain. We'll move on to questions from the audience at this point, because Anna, I'm going to bite 5 minutes into our next break just to give the panel enough time to kind of answer, if I may. If you can raise your hand, we've got people with microphones. Please, when you come first, we'll start in the centre here. If you can just say who you are and who your question is directed to on the panel, please.
Thank you. My name is Marion McNeill. I'm the Chief Executive of Precision Medicine Scotland. And I just really wanted to follow up on something that everybody's mentioned today in different parts. But Andrew, you've just touched on it beautifully. Data should be considered infrastructure. I couldn't agree more. And something that Aziz mentioned, I think is critical to this, which is information governance almost needs looked at as a whole across the whole country so that there's a really clear way through so that research can happen at speed and scale. And I just wondered if anyone on the panel had any sort of inputs. I mean, yesterday I was fortunate to meet Professor Tan from Singapore, and we talked briefly about this. Is there any learnings from Singapore or from the National Academies of Medicine that would help with that?
Sure, Chuan.
Yeah, we learned a lot from you. So I'll just replay some of the things that you have discovered and shared. I think it starts by being clear what the endpoint is. So in our case, we wanted to start with a clear research health data interface. The second is to understand where are the real bottlenecks, and permissibility and governance are the key ones. And we set up a structure which we systematically worked on this, even as we pursued use cases, because we needed use cases to make sure that the discussions didn't become too theoretical, or you can worry about a lot of things, but having use cases helps focus attention on the types of things. And we did it in stages so that we had a proof of concept to show that the sky didn't fall down, that actually good things can happen, and we'll be able to then earn the confidence of everyone to move on to the next stage. And so this has been for us a 4-year journey, and I think we go into the 4th year now with enough confidence to scale, both in terms of the data sets that are brought on board, as well as the users. And we are starting now to just talk with a limited number of industry partners just to learn how we would do that. And the final thing I'll say is we also are enlarging the armamentarium of the things we can use to interrogate data, like federated learning approaches, because there will be situations where data cannot be moved from one place to another. And so we do need a toolkit which allows us to be able to apply them. And having a very strong data infrastructure, as Andrew says, provides us the opportunity to really validate which of these different federated learning approaches really work well in other what situation. And then with that, if we have a sufficiently sophisticated toolkit, then I think we will be quite well placed to be able to use the data effectively as well as securely.
Thank you. This is when you wish you really had got your eyes tested. There's a gentleman at the back here.
Gregor, thank you. Peter Donnelly, University of St Andrews. It was great to hear the panel talk about equity in the context of research development and innovation. But there's a particular new divide that I think faces us as we go forward. And it's the divide around information, access, usage, understanding. It's the digital divide. To take a trivial example, my late parents, I remember them struggling during COVID to go into a restaurant and to figure out how to order a cup of coffee using their phone and the digital memo. And it's a trivial example, but when you then apply that to access to certain points of healthcare, there is a real challenge facing us. How to make sure that the benefits of the integration of technology that you're all speaking about is undertaken in a way that allows everybody to benefit, so that we don't accidentally make inequalities worse. So any thoughts on that from really any member of the panel, Gregor, to be honest?
So I think the whole concept of digital exclusion is one that people are very alive to, and perhaps I could turn to Victor first of all,
Sure.
just to give some thoughts.
Thank you for that question. In fact, when I talk about equity, it includes the digital divide, because it's the whole equity concept. This is a very important issue, because I think maybe in Scotland, about a third of your, at least low-income families or people don't have access necessary to Wi-Fi, you name it. I live in Durham, North Carolina, and during COVID, we discovered that many of the students who had to go virtual learning actually did not have either device or even access. So we had to actually went through a whole kind of fundraising and opportunity to get device for them, but also hotspots, because they can't really have direct access to Wi-Fi. So it's a real issue. I think it's a fundamental issue for the society to be able to increasingly make these technology accessible, easier, and certainly education is an important area. But in terms of healthcare, there are models where people are now using data-driven community care. That is, the caregivers have access to the devices, you know, apps, data, whatever, that can connect with, in fact, the clinics and hospitals, et cetera, so that they can actually go into community, which is what I was trying to say. It's not just the GP. It's actually community health workers that can use this kind of device to work with people who don't have access to it. So that's another way of looking at it.
Thanks, Victor. I have 3 people waiting to ask questions, and let's see if we can be brief so that we can fit them all in before we close. David.
Thanks very much. My question allows me to remind people that it's 300 years since Adam Smith, another distinguished Scot, was born. There are 2 points that came up: inequalities in the talks, and the importance of the private sector industry really to deliver our ambitions. And I think everybody's agreed on that. My question is, how important is it, therefore, to monetize the problems that we see, i.e. the problem of inequality, and what's our appetite for dealing with that? The public sector, I suspect, will never be able to address all of it. And it turns to the issue of data, what we do with it, how aside from information governments, our alacrity for monetizing that to address the issues of inequality.
Thanks.
And I suppose that's to Victor, but anybody can take it.
I'll give it a try. I'm not saying in any way that we shouldn't have a market-driven innovation. I mean, it's worked extremely well. Private sector have the resources and the bandwidth to actually now make these products available from development, also from marketing, you name it. And I think the government is not in a position to do this. I think the difference is, first of all, asking, the question is, have you considered equity access into the equation? Government has the opportunity to think along those lines in a relation with private sector, right? In our country, it is whatever the market can bear. We put it out there, and someone will pay for it. And gene therapy of $3 million, well, guess what? Someone's going to pay for it. But actually, it's the taxpayers and all of us paying for it. So I think there ought to be a clarity in terms of expectations. For example, conditionality. NIH puts in so much money, like $40-some billion a year for research. And it should be that if private sector takes one of NIH-supported research and commercialize it, we should get a piece back for both in terms of reinvesting in research or to be able to negotiate the drug prices, which we're not able to do in our country, believe it or not. Right? So I'm thinking along those lines. You need the private sector, let's face it. During COVID, who are the ones that came up with mRNA and others? But I think the public-private relationship needs to be recalibrated and not a one-way direction, in my opinion.
Thanks, Victor. Okay, so if we can keep the question short, we might fit into...
Richard Weller, Edinburgh. How do we maintain confidence of the public in their data being used? I mean, Aziz was showing how rapid access to data saves lives with Eve 2. And yet the public want kind of governance and security and everything and structures like that. And also if we are linking with the private sector, for instance, you know, Apple devices gives masses of personal data, which would be wonderful to get to. And yet their interests are commercial how do you make Apple happy for their data to be used? How do you make the public feel secure in their public accessible data being used?
Who's that aimed at, Richard?
Sorry?
Who is that aimed?
The same, really, at the panel, I suppose. At the panel. Just, it's a general...
Chairman's prerogative.
I mean,
I'm actually going to
data
turn to Andrew
confidence
for
is
this
a
one.
key question.
Okay, so great question. So data is an intangible asset. And actually, there was a Treasury report just pre-pandemic. The 5 richest companies in the world at that time were 3.5 trillion data. 95% of their value was in intangible assets, which was IP, data, and knowledge. The public sector in the UK, 2% is intangible assets. However, we curate a lot of data. The work we've done through social science and engaging with the publics, because it's plural, is that they're looking for trustworthy, transparent ways of working in partnership with industry. And there are some principles. Firstly, use of data has to be in the public interest and needs to be independently assessed. Secondly, it should be non-exclusive access to data. Thirdly, there needs to be the sense of a benefit share, so that if value is created, how is that shared across the public-private partners? Fourthly, the publics can actually guide you about what is trustworthy. I often quote Osler, who you know is the father figure of modern medicine. He said, if you listen to the patient for long enough, they will tell you the diagnosis. It's the same in the use of data in healthcare. And as Aziz showed on Generation Scotland, engage the publics, and they will help you shape a trustworthy system that's honest, reliable, and competent as we derive a new social contract. It's not easy, but we will need to approach it, in my view, with those principles.
Thanks, Andrew. Okay, so last question. How could I fail to give the last question to my wonderful CSO, Anna Dominicek? Can I just before she starts, I'm just going to say congratulations on turning 50, Anna. And many congratulations to you and actually to all the team from CSO who are here in this audience today for putting on such a wonderful conference as well. So well done.
Great,
Anna.
great. The CMO normally doesn't praise us, so let's just enjoy. I have a quick question to Andrew, and it links with what you already said, Andrew. So 10 years ago, when you were the CSO, Scotland was at the forefront of data. Everybody talked about Chi number from cradle to grave. We were there. Other people were learning from us. We are between friends, 500 of friends. And I'll be completely honest, we're no longer there. And we all know it. You are a diplomat, Andrew, but I want you to be less diplomatic for next minute or so and tell me, I think there are 2 things we need to do tomorrow, and we have some people who can help us in the room. What are these? In private conversation, you told me about wiring, and IG. And I suspect that these are 2 things we need to really kick hard. Please tell me.
So before we turn to Andrew, who had the sweepstake for how many times we're going to hear information governance being raised today?
So, just a couple of comments. So I do think that with the publics, we need a deliberative discussion about a national data strategy for health and social care to really deliver benefits across the 6 qualities of domain. Marion, I would argue that IG not only conspires against research, it conspires against care. I remember doing clinics in one health region and I couldn't get lab data from the next. It's madness. You know, to do this 14 times is madness. So I think supporting our colleagues to have a national data strategy, which hand in hand works with the publics in a deliberative way, which articulates the risks and the benefits and how we have safeguards in the system in terms of anonymization, authorization, consent, to actually leverage the value of data to improve people's lives. So, and I think now's the time to do it. final comment?
Go on.
I had the privilege of supporting Scottish Government during COVID. I'm now chairing the Scottish Government Standing, it's got a long name, Standing Committee on Pandemic Preparedness. We have 4 recommendations, and the number 1 is let's have a more mature, ambitious approach to data as infrastructure for the benefit of the citizens of Scotland. So please, let's do it.
That sounds like a wonderful point to leave this conversation. But before we do, can I just thank Andrew, Caroline, can I thank Victor and Chuan especially for your very generous answers that you've given today, and I hope that you found this interesting and informative. It's refreshments now.